Hello, this is Dr. David Greene, founder and CEO of R3 Stem Cell International. Today we're discussing quality assurance standards for stem cell biologics, such as those we use at R3 International. So here's an outline of what I'll go through. First is, where do the biologics come from? What tissues are included? How are they processed? What does the FDA require here in the U.S.? And then what are we looking to prevent, such as communicable diseases, versus what we're looking to promote, such as high cell counts. And then I'll discuss what are the actual risks involved. So first of all, where do these biologics actually come from? Well, what we're using is allogeneic tissue, which means it comes from a donor, and these are consenting donors after a scheduled C-section. Why do we use a C-section? Well, first of all, it's scheduled, right? So we have time to get the consent form from the mother, also perform a hefty screening process where blood work is taken, there's a large list that the FDA requires. In addition, there's a mental health questionnaire, and the medical director will review the medical records from the mother as well. Another reason it's a scheduled C-section is because of sterility. You know, it's a sterile procedure in the operating room, so contamination is absolutely minimized, if not eliminated. And then the yield. You get a full placenta, umbilical cord tissue, and amniotic fluid. If you use a vaginal birth, there's some issues with potential contamination of bacteria, and also the water has broken hours before, so you don't get the amniotic fluid. So that's more reasons why a scheduled C-section. So when you're talking about what the tissue is that is normally considered medical waste after a scheduled C-section, it's the umbilical cord, the placenta, and the amniotic fluid. The mother's fine, the baby's fine, and this tissue is then, instead of being discarded, it's taken to the lab for processing. Just one slide on the ethics involved here. Like I said, this is tissue that's normally discarded. There's no harm to the baby or mother at all. There's no embryonic stem cells. We only use mesenchymal or hematopoietic, and there's no compensation. So it's not that we wouldn't like to pay the mother. It's just that ethicists have decided, because this is a procedure that normally is undergone to have the baby, then you're not supposed to pay the mother for that like you would for an egg donation. All right, so let's talk about the quality assurance processing. We'll go through pre-processing, the processing itself, storage, distribution, and reporting mechanisms. So in the pre-processing, the quality assurance begins with review of the donor's medical history. So as I mentioned, the medical director will go through a lot of things. One is looking for blood-borne pathogens. Another is a review of the mother's medication history, whether there's a hereditary or non-hereditary diseases or anomalies. Looking at a history of alcohol, drugs, tobacco products, vaping, and then a history of tattoos. So it's pretty extensive. Only about 10% of eligible donors, who would like to donate, make it through that process and become eligible. When the C-section actually occurs, as I mentioned, it's a sterile procedure in the operating room, and when the tissue is obtained, it goes into a sterile container. It's immediately taken to the lab for processing, because time is precious with live cells, and it's processed right away. It doesn't sit there for a few days, until, like over the weekend or something like that. So where does the processing occur? Well, in the United States, these are FDA certified labs who are registered with the FDA. They get inspected every year or so to make sure that they're up to snuff, which I'll show you in a second. In Mexico, the FDA type of company is called COFEPRIS, and they certify labs there. They do inspections too, and if the FDA decertifies a lab or COFEPRIS, then we're not going to work with them. So what are we looking to prevent? Well, here's an actual product analysis certificate that shows what was evaluated for as far as bacteria, communicable diseases. So first of all, you see Lyme disease being checked, Chaga, CMV, hepatitis, HIV, syphilis, more tests for hepatitis, West Nile virus, and then sterility. That looks at for bacteria, whether it's gram-positive or gram-negative, and then culturing to make sure there's no growth present. So that's pretty extensive testing. It's not done at the lab itself. It's actually sent out to a third party that's accredited by a company called CLIA. All right, so the FDA lays out what it means to be CGMP, which stands for Current Good Manufacturing Practices. And it might sound a little bit nebulous, but when you actually look at the systems that are in place, they're very specific. Strong quality management systems, obtaining appropriate quality raw materials that you're going to use during the processing, robust operating procedures. So if you go into a lab that's CGMP compliant, they'll have extensive policy and procedure manuals showing exactly how they perform the processing, monitor it, track everything. Every step is written down and tracked. Detecting and investigating product quality deviations, maintaining reliable testing laboratories. So it's not worth getting into the nitty-gritty of the specifics of these, but it is a very robust process. Now, once the tissue is finished with the processing, it stays in a quarantine freezer for 2 weeks, and it's a liquid nitrogen style freezer, negative 192 degrees Celsius. And like I said, the testing occurs at a third-party lab. It takes about 2 weeks. And if all the testing comes back negative, then and only then can the tissue be sent out, for use. If anything comes back positive, all of it gets discarded. So traceability. If a problem were to occur with a procedure, then every vial needs traceability back to the donor. Okay, so that's one of the reasons that with CGMP compliance, every step of the processing gets tracked very specifically. So if there is a potential recall necessary, then the lab would be able to know exactly where that tissue came from, where else it was sent to, where they need to contact to get recall. That's what we're talking about there. Now, additionally, we're looking to prevent mutations and tumors. So let's get into that. First of all, let's talk about culturing. In the United States, cultured biologics are not allowed to be used. The FDA calls that maximal manipulation, but you can do it internationally. So we use cultured biologics frequently. There is a concern over mutations when you do culturing because you're going, replicate, replicate, replicate. Our labs use something called karyotyping to look for mutations, and if there's, a bunch of them, then it's all discarded. There is also concern over over-culturing. If you culture a biologic over and over and over and over and over too many times, then you're going to make those stem cells non-functional. It's called senescence. Okay, so we make sure that that does not happen. Our specimens are only cultured upwards of 5 times, and that's it. So it's also important to evaluate for stem cell counts and exosomes with surface markers, not just with a cell counter. We'll get into that in just a little bit. But I want to show you a couple papers of how, for instance, Wharton's jelly stem cells. Wharton's jelly is part of the umbilical cord that is very specific for tons of stem cells, but that does not induce tumors. So this was an animal study where they received human Wharton's jelly stem cells, and none of these animals developed tumors at all. This was a human study for the tumorigenicity evaluation of umbilical cord blood-derived mesenchymal stem cells. And what they showed is that both in the lab and inside the body, the umbilical cord blood stem cells did not exhibit any tumor potential. So very safe from that regard. Now we're also looking to prevent rejection. That would really stink if you got a stem cell biologic and your body rejected it, right? So will it cause rejection? Here's a great paper from 2007 about cord blood. Do you need immune suppression like you would for an organ transplant? Well, let's look at this. In the 1930s, cord blood was actually used for transfusions. There was a big shortage of blood donors at the time. They didn't even have HLA matching back then, and they didn't have any adverse events in many procedures. 1999 to 2004, there was a study of 129 patients who got cord blood, and they didn't have ABO matching or HLA matching, and they didn't have any rejections, and they followed these patients for up to 4 years. So there has not been any evidence of graft versus host disease with cord blood treatments. Actually, in this day and age, cord blood is now used for treatment of graft versus host disease. So that's how amazing it can be. Now here's another paper, the impact of graft recipient ABO compatibility. And what they found is that in 270 patients, they didn't even check for ABO status, and it didn't seem to impact outcomes at all. There was no rejection. One last study, this one's fantastic. Donor to recipient ABO mismatch does not impact outcomes of allogeneic hematopoietic cell transplantation. So it didn't matter if it was matched, unrelated. ABO matching is not a critical factor because no rejection is seen. All right, so we're also looking to prevent stem cell death. If you're getting a stem cell therapy, obviously you want to get live cells, and a lot of them. So here's some things that can cause stem cell death. One is if the tissue is delayed in the processing. That can be a problem. Cells can die. If you use too much preservative, it doesn't preserve the tissue. It actually can kill it. Radiation, I have no idea why labs use radiation except maybe to save some money during the processing. It's terrible. It kills live cells, and it's just a bad practice. Using too many reagents, handling the tissue very rough, or using very poor cryogenic technique can kill cells by membrane shock, things like that. So what type of cells are in the umbilical cord? There's a lot. Hematopoietic stem cells have been shown to be superior to those in adult bone marrow in basically every way. There's angiogenesis stimulating cells, ASCs. There's mesenchymal stem cells, and those have shown the ability to transform into neuronal, hepatic, osteoblastic, cardiac, chondrocyte cell lines. There's a lot of exosomes, which are stem cell byproducts, fantastic for helping with regeneration. In the umbilical cord, the mesenchymal stem cells are capable of replication up to 20 times without having significant problems. Bone marrow is only up to 5, and adipose, which is fat, is only up to about 8. So it's much more proliferative. All right, so the analogy that I use for the umbilical cord tissue, all the different cells and proteins, is that of an orchestra. Now, I'm not going to pretend to know what all these sections are. I just know there's a lot of different sections, okay? Those sections are akin to these different cells and proteins that combine together, just like the instruments do, to make the sum greater than the parts. So what you're talking about here is not just stem cells, but tons of growth factors, exosomes, secretomes, microRNA, cytokines. I spelled that wrong. But anyway, there's a ton of different regenerative elements in play. And you don't want to use radiation or too much preservative to kill them because they're all important. Now, when you use poor technique with cryogenic freezing, you can get crystal formation, osmotic shock, membrane damage, and that's all terrible. Proper technique involves minimal preservative, no more than, say, 10%. Establish vitrification techniques, which is a very fast method of freezing. It goes in less than a second from 37 degrees to negative 196 degrees. So that can be very effective, and it takes a knowledgeable scientist to make that in place at a good lab. That's what we use. All right, so let's switch and look to what we are trying to promote. One is cell counts. Another is intact variety of regenerative elements, i.e. the full orchestra. We want to make sure there's not just a lot of cells, but that the activity of those cells is in place. Biocompatibility, meaning no rejection. We want to make sure it's cost effective. If it costs way too much to make a biologic, then who's going to be able to afford a treatment? And then, after all of that, great outcomes. So here's an example of how our labs look at cells and exosomes to see if they're present. They don't just run it through a cell counter, but they also look at surface markers, which makes it very specific for, if we say a product has 30 million stem cells, these are the kinds of methods used to show that. So for instance, exosomes have specific surface markers. You can see here CD9, 63, 81, and this looks at those specifically. Because if you just run them through a cell counter and look at size, there's lots of other things that can be that size, like trash proteins and dead cells, and you get these inflated counts. So the goal and the reality is that there are many studies to date have shown that umbilical cord tissue is safe for clinical use, including Wharton's jelly and umbilical cord blood components. You don't need preconditioning or ABO matching. The tissue does not lead to tumors. It's non-tumorigenic. It does not lead to rejection. It's called immune privileged. Any adverse events in all the studies and our experience with over 15,000 procedures to date have been mild to moderate and resolved within 24 or 48 hours. What have we seen with the biologics? Maybe a low-grade fever for a day, some dizziness or lightheadedness, maybe a little bit of nausea, maybe some chills, and the chills are usually because maybe the IV fluid is a little cooler than the body. We do warm it up though. Basically things like that. The indications for umbilical cord tissue continues to expand very rapidly as each year goes by. So let me tell you about our international treatment program. We have several clinics and we're growing every year. We have 3 clinics in Mexico now, 1 in Pakistan, and then in addition to what we have in the U.S. But the clinics are only 20 minutes from the airports, whether it's the San Diego airport going across the border. It's very fast. Cancun is only 20 minutes, same with Mexicali, and then Islamabad as well. The process is simple. It starts with a free phone consultation with one of our licensed, experienced stem cell doctors. They will look at your medical records, will help you obtain those if necessary, give you the time to answer your questions, and then come up with whether or not you are a candidate. We looked at our data from last year. We turned away about 20% of individuals for various reasons. So everybody is just not a candidate. We don't want to give unrealistic expectations. Then you would have a patient concierge representative to assist you with all the travel logistics, including flights and ground transportation. The ground transportation is included in any procedure pricing. The cells. We talked a lot about cells during this presentation, but we do have a pristine safety record. The quality assurance is more stringent than the FDA. If it's in the U.S., obviously it abides by the FDA and above. In Mexico, the quality assurance, I've done videos on this, is just head and shoulders above what the FDA requires. We do culture the umbilical cord stem cells. We use minimal preservative, less than 10%, or in some cases no preservative. We can get the cells there the same day as the procedure. So what you end up with is anywhere from 90 to 95% viability. If we have to cryopreserve, it ends up killing about 5% of the cells. We overculture to compensate for that. And these are pure, potent stem cells below the 5th generation, as I mentioned. So R3 has been featured on every media channel you can think of. This year we were named the USA's leading regenerative therapies provider. So the process is easy to start. You can visit us at r3stemcell.com. You can live chat with us. You can fill out a contact form or just call us. Use the USA prefix and then 888-988-0515. And as long as you use the USA prefix, it'll work worldwide. All right, thank you so much for watching. Visit our website. Like I said, you'll see a lot of educational information, more videos, and we look forward to speaking with you.